I'm going to start my presentation a little bit gloomy, if you don't mind, but it gets much more positive towards the end, so bear with me. Clicker not working. Thank you. Yeah. Okay, so around the world, many of us working in healthcare, and certainly many people on the receiving end of it, have got a growing sense of unease that all is not well in healthcare. We have rising costs, and we are often not meeting the needs of our population in the way that we would wish. I qualified as a GP in the same year that IFIC was founded, I believe, and many of us have been working towards integrated care, and we've made great strides. But if you ask patients, many of them would say we still have a way to go. Part of that, I think, is because we designed our systems years ago for a population with very, very different sets of needs to those today. We have a lot of people living for a long time with chronic health needs, far more than we had in the past. And we also have the opportunity for growing technologies, which are very costly within our system. There's also low value care, isn't there? And some of that we drive ourselves as clinicians. If you ask a person who has chronic healthcare needs what their life is like, they will tell you that actually it's a full-time job going back and forth to their different healthcare providers and trying to coordinate their care. It really is a full-time job. So why have we struggled? Well, many of the reasons, I think, are behavioural, and we have to, all of us, change. And the only way that we're going to change is if we work together. So I'm going to explain a little bit in this presentation why I think value-based healthcare can help us do that. But we really need to challenge ourselves, all of us, clinicians, patients, managers, policymakers, to think differently and act differently. So value, how does value help? Well, the first thing I'm going to call out is that value is a tricky word and is differently interpreted around the world. So we have Michael Porter's theory from Harvard Business School, value equals outcomes over costs. Value being looked at as a whole system value. So you can't look at value from the perspective of one organisation or one hospital or one primary care facility. You have to look at it from the point of view of a patient or a population of patients with similar needs. And we have to look at the costs and the outcomes across that whole system of care to decide what value is. But value is quite subjective. In order to do that, we need to understand the outcomes of our patients, as was mentioned in the Minister's speech earlier on, and that's something that we've consistently failed to do over the years, having measured process measures more than actually what matters to people. Have you improved my pain? Have you improved my sleep? Am I able to go surfing? You know, these are the things that matter to patients. Have we allocated resources in an optimal way to achieve those outcomes? And have we distributed those resources equitably? Equity is of major importance, I think, in Australia, and certainly is in Wales as well, and that's why I think it's very exciting that our healthcare systems can work together on this. We also have an issue with thinking about the value of different interventions. We tend to, as healthcare systems, default towards new technologies, putting our resources into new robots or a very expensive new drug. Now, often that's very exciting, and those new innovations take us great leaps forward, but not always. Sometimes we get very marginal gains from those high investment into new technologies. And that's often at the expense of things that are seen as softer interventions, like the care that a nurse practitioner might give a patient in the community, end-of-life care or prevention. So value, for me, is about finding the sweet spot of a balance of resources across a whole system of care for individual patients and populations so that we get the very, very best outcomes. And sometimes that's going to mean some tough decisions, isn't it? So what are the consequences in the healthcare system of not knowing the outcomes that matter to patients? Well, this is Voltaire, famous French philosopher, and he said this about 300 years ago. So doctors pour drugs of which they know little to cure diseases of which they know less into patients of whom they know nothing. Still true. Still true. Evidence-based medicine has taken us on a very long way, of course, but I would argue that Voltaire still has a point. Actually, he didn't like doctors very much. If you Google Voltaire and doctors, you'll find a bunch of quotes that basically say we're all quacks. So, so you take it with a pinch of salt, but he has a point. So what are the consequences? Well, we don't understand the effects of multimorbidity. So the gold standard in evidence-based medicine are randomised controlled trials, aren't they? So increasingly randomised controlled trials exclude the populations, the very people that we will want to use those treatments in the first place. And we extrapolate evidence, and then the evidence goes into guidelines, single disease guidelines, and guidelines then sort of become rules, things you should do. And the truth is we don't have any idea about what the impact of some of these treatments are really going to be in the real world for people living with multimorbidity. So we need to track outcomes after trials and try and understand what's happening and try and ask people what their goals are. Because we also know very little about patient preference and context. And you can have a pathway, an evidence-based pathway, that's great. But actually, if you're not asking people what they're seeking to achieve with their life, that's useless. So if you've got a surfer, you need to know that guy wants to go surfing. It's a great example. Unwarranted variation. We've been talking about variation in healthcare for years, haven't we? But actually, it's very difficult to tease apart what is warranted from unwarranted variation unless you speak to patients and unless you understand some more about outcome measurements. People often have very incomplete information and advice when they're trying to decide on a treatment. So if we think about an example like chemotherapy approaching end-of-life care, there are very real trade-offs there, aren't there, between length of life perhaps and quality of life. How honest are we with patients about that? And how much information have we got to reflect back to people to help them make a decision about those trade-offs? And then the final one about not knowing outcomes, not knowing what's happening with patients, is we don't actually have any way of objectively knowing how people get on at home. So what's our response to that as clinicians? Well, I can tell you my response to that as a GP. To make myself feel better, I get people back to the surgery, to follow them up quite a lot. Well, that makes me feel better. And it might sometimes make the patient feel better, but not always. If you've got multiple providers of your healthcare, multiple doctors, multiple organisations sometimes, and you're going back and forth, patients tell us that sometimes they just walk in and are told, yeah, you're fine, and then they leave again. That's probably been a day out of their schedule. They've probably had problems parking and, all of the usual things. So actually, a lot of healthcare, low-value healthcare, creates poor experience for patients. And as clinicians and healthcare providers, we need to find a way to let go a little bit and let patients control their own care. And I know in integrated care we've been trying to do that for years. So how are we going to do that? Next slide, please. So I'm going to give you 3 tools which I think can help us with some of this and help us achieve integrated care by looking at it through a value-based healthcare lens. The first is to encourage us all to take a whole system view of costs and resource allocation, but also of need, and to be really sort of service blind, so not to think about this as a hospital or a primary care or an organisation, but to think of it from the perspective of the patient or the population of patients. The second is to turn outcome data and other data into intelligence, into information that's going to help us with our decision making, because it's amazing how many decisions we make in delivery of our healthcare systems with very little information about what to do, and how poor we are at evaluation at times. So how many pilots have we seen that don't get rolled out when they're successful? And the third one, and probably the most important, is patient power. So first of all, whole system view. So how often do we see the big picture? So I'm still a GP, but when I was just in my GP practice and I wasn't doing anything else, I was definitely in the space of seeing one piece of the jigsaw puzzle. And this is what patients see, I think, is just a jumble of pieces of the jigsaw puzzle, and they're trying to put the pieces together for us very often. And we need to come back from that and take the helicopter view to decide how healthcare services should be delivered for patients. And patients very much need to be involved in that. If we don't take the wider view, it's almost impossible to see how to allocate resources for highest value for patients. One of the common arguments that I've seen come back from colleagues of mine is, well, we just need more money, we need more staff. But actually there's a real problem with sustainability here, isn't there? And we do need to talk about resources. We need to talk about money, yes, but we also need to talk about staff resources. In Wales, where health is devolved from the UK government, we spend roughly about 50% of our devolved budget on health. And the other devolved functions are on the environment, on education and leisure. The more of the cake, the more of the pie that healthcare absorbs, the less there is for the very things that make us healthy, wealthy and wise. And healthcare accounts for only 20% of our health, and we need to really bear that in mind and be careful when we're banging the table for more resources. So we do need to do better with what we have, and the only way we're going to do that is if we radically transform our systems and take that whole system view. Next slide, please. So this is a slide I borrowed from a colleague of mine in Wales who's working on the National Clinical Plan at the moment, and I've put this in here to illustrate my point. You'll notice that there's no organisational or location of services described within this slide. It probably contains many elements that you interested in integrated care are very familiar with, and describes end-to-end what we might do from prevention through to end-of-life care, and the sort of skills and interventions that are needed to deliver value and high-quality care for patients and improve their outcomes. So this can be applied differently depending on the context, and it can be modified to look at any subpopulation of patients. And the reason this is important, I think, to display it this way and to understand the costs and outcomes for, in this case, a population of frail elderly patients, is that we need to understand and work with our finance managers to see what we need to invest in prevention and end-of-life and supportive health and social care, as well as new technological developments. Because there are many things that provide value for patients. Improving quality of life, increasing length of life, but also having a good death. Because all of these things are part of life. And if we focus on one at the expense of another, we will not deliver value, what matters to ourselves and our families. Next slide. So, I mentioned data, outcome data, and variation data, costing data. There's lots of data that can help us with value-based healthcare, but the major gap, as has already been highlighted this morning, is with patient-reported outcomes. So I'm going to focus on that a little bit for you. So patient-reported outcomes, in a way, is a bit of a misnomer because an outcome is not just an endpoint, the result of a treatment or an intervention. It is a structured, enhanced communication between patients and healthcare providers that could be a milestone or a consequence as well as an endpoint. So it's a status of a person at that point in time. So that's very, very useful as a communication tool, and there are nuances around how we might use that information in cancer, in chronic non-malignant disease, in multimorbidity, or, as has been more common in the past, in episodes of care like after joint replacement surgery or cataract surgery, something like that. But the use of patient-reported outcomes is very much richer than has been historically the case. So they are extremely useful when we start to embed them in direct care, and that is absolutely the way we have to deploy patient-reported outcome measurement, otherwise this does not become a sustainable exercise. This has to be about embedding in direct care and enhancing communication. When we do that, it's an excellent symptom tracker. Ooh, thank you. And can support shared decision making. It can be triggers for key conversations, for example, for advanced care planning. And when we aggregate up the data, we can identify unmet need. We can start to identify unwarranted variation and start to generate real-world information about what's really going on with groups of patients. So not to replace gold standard evidence generation, but to augment it. It's very interesting to see that Cochrane and NICE are starting to take account of the need to do this as well. So here's an example. What we've discovered in Wales is that PROMs are an excellent way of patients describing their needs to us. So heart failure is a very difficult condition. We have a lot of emergency admissions with heart failure and readmissions with heart failure in Wales. So the heart failure PROM here that you see is part of the PROM that we're collecting, and it focuses on mental health and on two key symptoms that patients with severe heart failure might have, so swelling in the morning and sleeping sitting up. So I'm going to focus on swelling in the morning and sleeping sitting up. So the way this is scored, you can very easily start to group patients into those that are stable, which is about 2/3, and those that have moderate or severe symptoms. Now what you see there, of course, is that most people are stable most of the time, but about a very consistent 15% or so of patients are having severe symptoms, and that's severe symptoms every day, because the question asks patients, how many times in the last fortnight have you had these symptoms? And for those severe patients, it's every single day. So those people are at risk of hospital admission every single day. Do we configure our services to meet that specific need, but perhaps be lighter touch with the patients who are well and stable? And the short answer to that is usually not, isn't it? We usually have a one-size-fits-all. So you can start to see how this sorts of information can not only help us with our individual interactions with patients, but can actually start to show us how we can remodel our services. So patient-reported outcome measurement should never be a data collection in its own right. If you set out to collect data from people involving clinicians and patients for nothing other than to collect data and for it to go off into a black hole somewhere, it will fail. And when you start to look at patient-reported outcome measurement, you realise that this is really about enhancing communication and, where possible, electronic communication with patients. And guess what? When you enhance electronic communication with patients, you can do a bunch of other tasks as well, which will help with value for patients and sustainability and some of the other problems that we have experienced in the past. So we need to give power to the patient. Patients often feel like they're herding sheep with their healthcare providers, and we need to give them the tools to herd those sheep. So when we enhance that electronic communication, We can give people information about their appointments. They can cancel and rebook their appointments. We could even just do a remote wave, you know, supported by a prom. I'm fine. You know, I don't need to come and spend a day at the hospital just yet. We can give patients access to their record, and they can share that record. They can see their tests. They can get flexible access to clinical advice and so on. And that also releases capacity within the system for us to spend more time face-to-face with those that do need that face-to-face time, and hopefully bring back some of the joy of clinical practice back to clinicians as well, who are struggling to maintain increasing amounts of activity with less and less time. So this is not about saving cash, it's about doing things differently, thinking differently. So finally, a summary. How do we achieve value for patients and achieve integrated care? Well, there are many factors, aren't there, from the point of view of patients and the point of view of healthcare. So, of course, we need to look at prevention, support healthy behaviours, raise health literacy, promote patient activation, and support the shared understanding of medicine, giving people as much information as they want and need to make better choices for to meet their health goals and achieve those outcomes that we've been talking about. And on the healthcare side, we need to decrease unwarranted variation and low-value care. We also need optimum positioning of drugs and devices. Value-based healthcare is not about promoting the medical industrial complex and generating loads of profits for pharma and the medical device industry. We want to promote innovation and quick access to technologies that are going to make a big difference, but we need optimal positioning. We need to understand who exactly benefits from those drugs and devices. The context is very, very important, so that we take ourselves from the standard population of an RCT to real population and understand what's happening in the real world when there is complexity. Therefore, generalised care to personalised care, and really understanding about personalising goals and focusing on meeting true need and equity. So I hope that I've convinced you that value-based healthcare is a very useful lens through which to look at integrated care and to provide us with a set of very interesting tools to help make our task, because it is a very difficult and challenging task, that bit easier in the coming years. Thank you very much.